I'm very pleased to chair this EHA 2022 guideline session on BSH EHA guidelines on use of next generation sequencing in the diagnosis of congenital anemia. It doesn't work, my key. Oh, okay, so here it is. So I have no disclosure to make. So first of all, we will listen to Dr. Yuri Alessandro Gianotta from Vilma Barcellini Hematology Department. Yuri Gianotta is a clinician and is from the Pathophysiology of Anemia Unit in Milano, Italy. And Dr. Gianotta will present 2 patient cases, which include a polling. So thank you for your participation during this polling. Then we will listen to Noémie Roy and Roberta Rousseau. And Noémie Roy is a consultant hematologist in Oxford University Hospital and honorary senior clinical lecturer at the University of Oxford, UK. Roberta Rousseau is an assistant professor of medical genetics in University Federico II. And she is also a molecular genetics and diagnostic supervisor in Sage Advanced Biotechnology in Naples, Italy. So all 3 speakers will talk about their experience in molecular screening analysis of hereditary rare anemia. And then we will have 20 minutes of discussion. So please, Yuri.
Okay. So good afternoon, everyone. I'm Yuri Gianotta. And I can't see my slides, actually. Okay. So I would like to show you through these 2 clinical illustrative cases, which are the pros and cons, lights and shadow of NGS and molecular studies in congenital hemolytic anemias, where the differential diagnosis may be highly challenging sometimes. My disclosures. So let me introduce you to the first patient who was referred to our clinic when he was quite old, like 54-year-old, but with a strong suspicion of hemolytic chronic congenital hemolytic anemia. His past medical history was indeed very indicative and typical for congenital hemolytic anemias: jaundice prolonged at birth, moderate macrocytic anemia with high reticulocyte count and altered hemolytic indices, splenomegaly, and gallstones who required cholecystectomy at young age. He also suffered from iron liver overload due to chronic hemolysis, which required iron chelation. At the local center of hematology, they excluded the most common congenital and acquired causes of hemolysis. In particular, they also performed the membrane and enzymatic assays to exclude CHAS, but also to exclude thalassemias. And all the tests, comprising bone marrow evaluations repeated twice, were unremarkable. No family history of anemia or of hemolysis. The 2 parents were not did not show consanguinity, but they came from a small village in the northeast region of Italy. So here are the tests that we performed. As you can see, we studied all the glycolytic pathway enzyme assays, which were totally normal. Only one unremarkable alteration at the AGLT test, which is a lysis test, but in presence of other lysis tests normal, it's not remarkable. You can see also the osmoscan, also known as ectacytometry, which is normal in these patients, and we revised the blood smear evaluation without revealing any typical alteration of the red blood cell morphology. So here my first question to the audience. You can start polling, open the polling. Which additional test would you perform to inform the diagnosis in this patient? First option, repeat second level, more specific direct antiglobulin test, or you perform a FLAIR cytometry to detect also smaller PNH clones to exclude acquired causes of hemolysis, or 2, you repeat bone marrow evaluation to exclude CDA, so the congenital dyserythropoietic anemia, or other bone marrow failures. Or 3, you go for an NGS study for unexplained congenital anemia. I think we can also stop the polling and see how the audience oriented on it. Okay. So basically, the first option is always a valid option because, as you know, not all the laboratories can perform high levels and very specific and sensitive DAT tests, but the patient still have a very informative history for congenital anemia. So the first option is quite improbable. And also the high reticulocyte count in this patient can quietly, with high, will likely exclude a bone marrow failure because of high reticulocyte count. You can see now the polling, sorry. Yes, almost all of you was for the NGS study, which is, I would say, correct in this case, because we are in front of a chronic hemolytic anemia of unknown origin, where all the acquired causes were most likely excluded and all the biochemical tests to perform on congenital hemolytic anemias were unremarkable and uninformative. So, as also Roberta and Noemi will detail you later, this is a strong indication to perform an NGS study. And in fact, our patient showed to be a compound carrier, compound heterozygous carrier of 2 pathogenic missense mutation in the PK gene for pyruvate kinase. So he received a molecular diagnosis, notwithstanding a normal enzymatic assays. This changed, in this case, NGS changed his clinical history because we could enroll the patient in a clinical trial with mitapivat, which is the oral allosteric activator of red blood cell PK, who allowed him to reach normal hemoglobin levels and to normalize hemolytic markers in few weeks. And surprisingly, also in few months, he could stop the ferracirox, the hydrochylation, because the chronic hemolysis ceased. But now let's turn to the second case, in which you can see the scenario is more complex and even more, I would say, anxious and difficult, because we are in front of a preterm newborn male with severe anemia with altered hemolytic markers, who was inducted to labor for anhydramnios. He was transfused with 1 packed red blood cell unit and transferred to our neonatal ICU to receive proper care, which consisted of also 3 more packed red blood cell units and also EPO administrations. So here we are in front of the same case of unexplained anemia as the first one. We have maybe less informative history because the patient was still born. And so my question for you, you can open the polling. Which test or better strategy would you use to inform the diagnosis in this clinical context? You would perform red blood cell membrane and enzymatic studies on patients' blood sample, or you would do the same stuff but on the parent's blood sample after recording a careful family history, if suggestive, and or go directly for an TNGS study for congenital anemia, since the patient is ill and we need a diagnosis. Let's see the polling. Okay. You can stop the polling. Okay, so 37% of you adopted this very, I would say, wise strategy of carefully analyzing family history and study not patients, but parents' blood sample, because since the patient is transfused, we don't have the ability to really perform studies on patients' blood sample. So this is correct, I would say. But 62% of you did what we actually did at first. So this is straightforward TNGS. Let's see how we manage the patient. This is what we did. So just a quick screening, first level screening to exclude most of all the acquired causes of hemolysis. So autoimmune hemolytic anemia with a negative Takehome test. But all the more illustrative and informative studies on patient blood sample were not done because of the recent transfusions and the urgent need for additional transfusion in the incoming days. The parents were just screened, not actually very asked for their history, but just screened with some first-level tests, which were unremarkable for thalassemia and stuff like that. So the neonatologist requested us to perform NGS study because the suspicion for congenital dyserythropoietic anemia was quite high, notwithstanding the high reticulocyte count, which is quite uncommon to see in CDA. In fact, we are in front of the same case as the first one, but with much little and fewer information. In this case, the NGS revealed no pathogenic mutation, which obliged us to reevaluate more carefully and with more calmness the clinical and family history of the patient, since the hemolytic markers still persisted altered, and the patient, but now was quite safe with an hemoglobin level stabilized at 8-9 gram deciliter. And now an illumination bumped into one of our lab's biologists' mind when we could first finally see the patient's parents. We could see that they were from Bosnia and Herzegovina, and they showed some degree of consanguinity. So we could think that they could be carrier of the so-called Roma community variant or gypsy variant of PK. Which is a very long, a big deletion in the exon 11 of the gene, which can't be detected actually at TNGS studies, but requires a specific allele-specific oligonucleotide PCR, which is what we did in the patient, revealed the mutation. And only now we performed the enzymatic assays, which proved pathological in the patient and normal, slightly low to normal in father and mother, consistently with their carrier status. So we get the diagnosis just only 1 year after the clinical onset, and maybe before if we only had waited some time from the last transfusion to perform all the enzyme and membrane tests in the patients. So here my take-home message is NGS can be considered a double-edged word in this clinical context of congenital hemolytic anemias, since biochemical screening of CHAS is less expensive and in most cases has the highest sensitivity to the diagnosis. However, NGS studies may allow the diagnosis of enzyme defects in falsely negative biochemical context, which is the patient number 1. But also molecular tests can be falsely negative, see large deletions in patient number 2. Therefore, NGS interpretation always relies on a thorough analysis of patients and family history. Thank you.
Okay. Thank you, Yuri. So we will text the questions. There is no question in the chat right now. So I've got a question for you. Actually, you found NGS in the infant, but I think as you said, you also test the parents. But I think perhaps you wait 1 year to test the parents, or you test it right away, or because in the real life, actually, I will do the NGS, but I will ask also the parents at the same time to do all the tests. So
that's correct. In fact, what actually happened in real life was that we lost the patient at follow-up because he was followed at the local hospital. He was just referred to our neonatal ICU for high-grade cares. So we did not know the patient so well. And also the parents were just referred to our clinic as outpatients when the proband was 1 year old. So that's why we perform the diagnosis and get the diagnosis so later, I would say. But in any case, maybe a more thorough family history analysis in the first day would have been the best choice, even because once you excluded the autoimmune hemolytic causes of the anemia in this patient, just by transfusing him, we could have all the time to reflect on the diagnosis, which is also a nice message, I would say, for the clinicians suggesting.
And it was not found on the NGS. You didn't see the homozygous mutation on the NGS. There is no the hole that we usually see when there is a homozygous deletion.
Sorry, Lydia, couldn't get your question.
You know, when on the targeted NGS, the regular one, you didn't notice the mutation. It was not like, you know, when we found the homozygous mutation, there is a big hole in the coverage. You don't see that in this mutation.
Actually, we couldn't because the deletion was like 1,200 base pair loss. So we should get an ASO PCR to demonstrate that the PCR was not like transducting all this whole gap. That's why all targeted NGS is not always the best choice, which is something that happens also in alpha thalassemias, where you would rather prefer MALPA analysis, gap PCR. That's it.
Okay. I think we can move. I don't have any question. I don't know if Roberta, Noemi, you've got one question.
Yes.
I think you can ask. Roberta, you got one question. Go ahead.
Yes. Next slide. Okay. Good afternoon, and thank you for giving me the opportunity to present with Noemi our good practice paper on next generation sequencing in the diagnosis of rare inherited anemias. We have nothing to disclose, them both. And this, our good practice paper focused mostly on inherited rare anemias that can be grossly classified into different subtypes: hyperregenerative and hypoprotective anemia, such as diamond black fan anemia, congenital dyserythropoietic anemia, sideroblastic anemia, and red blood cell membrane defects, both transport defects and structural defects, and finally anemia related to enzyme defects. These conditions share some clinical and also some clinical features, and indeed, for example, regarding the age of presentation, they usually present in the infancy or during childhood, and they may have also additional associated features beyond erythroid-related ones. The severity is highly variable because we may have some conditions that are most severe and other mild. And from genetic perspective, hereditary anemias cover all, more or less all the subtypes of inheritance, because we may have conditions with autosomal dominant inheritance pattern or autosomal recessive and X-linked recessive. Indeed, this wide group of disorders is highly heterogeneous, and more than 80 genes have been associated so far to red blood cell disorder, to hereditary anemias. And in our good practice paper, we briefly described also what are the available applications that are currently used in diagnostic settings regarding the genetic diagnosis of these conditions. As we know, the most used approach is the targeted resequencing panels. Several different panels have been developed by different laboratories, and they generally present a different number of genes, ranging from 20 to 200 genes, that include analysis of exon and also intron exon boundaries for the detection of splice site variants. The advantages of this type of approach is surely related to the relative easy analysis interpretation of data, because we obtained less data when compared with the use of whole exome sequencing or whole genome sequencing, but a challenge that is similar also for whole exome sequencing, as those just pointed out in the previous case presented by Yuri, that is, for example, the identification of chromosome imbalance or structural variants such as copy number variations. And another relevant disadvantages is that we have coverage that is often not so uniform. Regarding exome sequencing we know is an NGS application that is cover approximately 1.5% of the entire genome, but it is able to identify 80-90% of all known disease-causing variants. And the methods used for both targeted resequencing and whole exome sequencing are pretty much similar. They are based on capture methods. And the advantages is in the cost that is lower than when compared with the whole genome sequencing. One of the most important disadvantages is related to the interpretation of variants, because it is in this case can be difficult. And finally, whole genome sequencing. We can envision a future in which whole genome sequencing could be used in routine diagnostics, but we are not so ready for this approach currently, because we need a lot of bioinformatic and storage capabilities in the lab. And regarding WGS, this approach allows simultaneous identification of point mutations as well as structural variations. But also in this case, the interpretation challenging is one of the most relevant and limiting factor. Looking at the overview, a general overview of NGS testing pathway, we can say that generally we start with the blood sample, and after this we proceed with DNA extraction and quality control of the extracted DNA, and then we moving on the library preparation, and finally we start with the sequencing phase, that and with the subsequent bioinformatic analysis that can be divided into three main steps. The first is represented by quality control check of raw data, followed by read alignment and annotation variants and variant calling and after annotation variants and filtering. And finally, we have the most relevant step, that is the variant interpretation. That it can be in some cases highly difficult, and for this reason, as Noemi will say in the next slide, we suggested the multidisciplinary team to establish what kind of variants should be included in the final report. Okay, now I leave the floor to Noemi for the subsequent slides.
Thank you, Roberta. So when we did this guideline, we thought it would be most useful to divide it up into different questions so that people can look at the recommendations based on specific questions that you might ask yourselves in terms of setting this up in your lab. So the first question is, when is NGS necessary and or of additional value in the diagnosis of rare anemias? And we know from, for example, the two cases that Julie presented, that of course you could go straight to NGS, or you could start by doing many different physical tests on the samples first. And it would be helpful for users to know at which point is the best time to use the NGS. So the first recommendation is that, of course, we need to make sure that we have ruled out any acquired causes. And this requires the person who is carrying out the test to make sure that, for example, hematinic deficiencies have been ruled out, or other acquired causes that also cause anemia. We obviously need to make sure that the patients have had appropriate consent. And sometimes, of course, that will be the responsibility of the clinical team. But of course, there's also a responsibility for the laboratory to make sure that they're not processing samples without ensuring that consent has been taken. And with inherited anemias, there's always the question about globin gene analysis. And we've made sure to include that in the guideline so that people are clear about whether how the globin gene analysis should be undertaken, whether that should be part of the NGS panel or done separately. And at the end of the day, it doesn't matter how it's done, but it's really important that that it is considered as a differential diagnosis for some of the especially microcytic anemias. We thought about the particular types of anemias where it's really much easier to diagnose on NGS than for example, doing single gene analysis or certainly doing the more phenotypic tests. And that includes the DBAs, the CDAs, the sideroblastic anemia, and red cell enzyme deficiencies and membrane disorders. And I think you were able to see from, again, the cases that Jordi presented at the beginning, that doing all of the very extensive tests that you can do in the laboratory that don't involve genetics sometimes doesn't actually provide you with enough information, and that's why you need to do the genetic screening. Now, this is particularly true where there's diagnostic uncertainty. So you could think that if you have a case that is very clearly done in Blackfan anemia, the genetic analysis is less necessary to make your diagnosis. It might still be useful for prognostic information or to do genetic counseling, but in the terms of diagnosis, if you have some features clinically that are not very clearly one or other of these subcategories of inherited anemias, that's when the NGS is going to be particularly important. Then there's the cases where we need to do the NGS before we carry out in irreversible treatment. And so the two irreversible treatments that we were thinking about is both a splenectomy and a bone marrow transplantation. So for both of those, it's extremely important that you have the genetic analysis so that you don't make any errors in the treatment. And so for splenectomy, that includes making sure you don't have a piezo mutation, which would mean that the splenectomy would be contraindicated. And for the bone marrow transplantation, we need the genetic studies not only for the patient, but obviously also for any potential sibling donors to make sure they don't also have the same condition. So then the next question is, at which point in the diagnostic pathway should NGS be used? And this is actually a really difficult question to answer because if we're thinking about writing guidelines, then that should be evidence-based, and it's going to be very difficult to gather any evidence about the point at which NGS should be carried out. And this is going to depend on a lot of things, including what is happening in your country, what is the reimbursement, what technical capabilities there are in the lab, and that might determine whether you're using your genetic analysis very early or very late. And so in our guideline, we've left it up to the particular service to make that decision. But essentially, the important point to take home here is that you do carry out your history, your examination, and your blood tests, and then you think about your specialized tests, whether or not you need a bone marrow biopsy, and then your genetic analysis. And sometimes you would do the bone marrow biopsy only to confirm or refute a genetic diagnosis that's suggested by NGS. And in some cases, if the genetics is very clear, for example, in some of the CDAs, you may not need to do any bone marrow, and that's really wonderful for the patient that they don't have to undergo this procedure. So essentially, we use it once the phenotype's been characterized. And so the first thing you do is with your test is you try and work out whether it's what type of anemia it is. So is it hemolysis, ineffective erythropoiesis, or bone marrow failure? And which panel you use will sometimes depend on that initial diagnostic work. In other cases, you would have a panel that covers all of these subtypes, in which case you would analyze all of the genes on the panel for that patient. Now, when you're reporting your NGS panel, it's really important to match up what you're finding in the clinical scenario with what you're finding on the genetics. And that's where the people who run these panels will often try and remind the clinical teams that it's really important to fill out the request forms with as much clinical detail as possible. Because when you're reporting the variants, you need to make sure you report a variant that fits the phenotype. So our next question was, what are the important considerations in choosing your most appropriate form of NGS, and what quality criteria must be met? Now, obviously, as I've said, it will depend on your local resources and your required turnaround time. But we want to make sure that the laboratories that are carrying out these new types of tests are also very clear to work out what their limitations are when they run the test in their lab. And so if there's some regions that some particular types of mutations that won't be picked up or deletions, and I think the second case that Yuri presented is particularly important in this case, because sometimes you do need additional techniques like MLPA or gap fill to add to your NGS. And then finally, it's important that sometimes you can require further investigations, and some of these may be available in the diagnostic lab, and some of them may not be available and will need research. And then the last question, which is the most complicated, is what the criteria should be used for reporting the NGS variants that you've identified. And so we have to be very careful when we're writing the report about what we include and what we don't include. So the easy ones to include will be either pathogenic or likely pathogenic variants that do match the clinical suspicion. So that's a straightforward report. We do report some pathogenic variants that are not related to the clinical suspicion if they've got a clear role. So essentially what we're doing is we're writing a carrier status report. And that's important because once we've identified it, it seems that it would not be the right thing to withhold that information from the patient. So the really difficult questions come on when we're talking about variants of uncertain significance. And some labs will report variants of uncertain significance if they do match the phenotype, and if there's a specific phenotypic test, or for example, family testing that could be used to be able to determine whether that variant can become significant, either pathogenic or not pathogenic. But it's really important that the labs make it very clear to the clinicians that this is a variant of uncertain significance. We've also got in the guidelines some clear recommendations of what variants not to report. So that would be non-canonical splice sites, so where we basically don't know if they're having an effect at the protein level, and also some variants that are sort of at the edges of the genes, again, that we don't know if they're having any specific effect on the protein. So we also added in some additional information about family testing and when that can be useful. So last but not least, we have some guidelines about how labs should talk to each other, because these are rare diseases. It's important that labs share information that if they can help each other with finding additional information that help to determine whether the variants are significant or not. And I think in the interest of time, I'm not going to go into a lot of detail about this, but essentially we do have in the guidelines a very specific list about the criteria that a laboratory needs to be careful about if they want to offer clinical grade NGS. And that is very different from research NGS. And that's why we are very careful to spell those out. Thank you very much.
Thank you so much to all the speakers. So now the presentation are open for discussion and questions. So from the audience, do you have any question? I don't see any. I will begin. So I don't know if you assist to the bone marrow session, but we've got a discussion with Marcin Wlodarski about the fact that either we will begin with the phenotype going to the molecular diagnosis, or either an agnostic process, and you go to molecular diagnosis without knowing the phenotype. So what what do you think about that, and what's your comment about that, Roberta, Noémie? You want to answer?
Okay.
Question.
Okay, well, the problem is that in using NGS, we often see a situation in which we perform a reverse phenotyping. So we analyze also based on a few clinical data. We start with the analysis with genetic testing. We identify a variant, and then we reevaluate the case looking at the genetic findings. So this is an easy case in which we identify pathogenic or likely pathogenic variant. But the problem, from my point of view, is that when we identify variants of unknown significance that are the most relevant problem of using NGS, so in that specific case, I believe that it is always recommended to start with a careful phenotype evaluation before performing a genetic testing.
I agree with you. There are some cases that we can do the reverse, but yes, definitely agree with you. We've got a question from Immacolata Andolfo. What do you think about reevaluation and reassessment of previously identified variants?
It's a good question, and in fact, it partly answers what I was saying earlier about sharing data between labs. So, for example, in the UK, we've got 4 labs that provide NGS for rare anemias, and we've been sharing our variants, and we were able to find either, so essentially, usually it's actually to increase the pathogenicity of a variant. So some variants that we said were variants of uncertain significance, another lab had been able to say they were likely pathogenic because they had more information. So there were more family members, or they had done some functional studies. So it's really important that we do this sharing so that we can change our diagnosis and improve the diagnostic accuracy. It also makes me think about a question that patients often ask me, which is, if you have everything negative and then there's a publication with a new gene or new variants, do you then go back to all your negative cases and reevaluate them? And funnily enough, the patients assume we do that, but in actual fact, we don't do that. And the reason we don't is purely financial. So we won't get paid, the lab won't get paid to rerun all the negative cases. And that's a real problem, again, for patients who are given a negative diagnosis and nobody thinks to send the genetics again or to ask the lab to redo the test when we've got more tests available.
Yuri, can you explain to the audience why the large deletions are not usually seen on NGS and will be more visible in whole exome or whole genome sequencing?
Yes, I will try to. Since as a clinician, maybe I'm not the most perfect person to answer, but for what I can say is that with targeted NGS, we just decide to study some exons and some parts of the genes, of the panel of the genes that we want to study, which in our case, our lab uses a 40 gene panel for rare anemias. But in case of large deletions, it may happen that this region is not covered by the targeted sequence that you choose, even because they are very rare variants which are so specific of some geographical regions, so that you are not interested in studying them during a screening phase. What changed our point of view in the second case that I presented was exactly the family history of the patients, because their GPP origin and the previous results of NGS could inform us to go on and to specify another kind of genetic test. But actually is not said that you have to do that ASO PCR as first, unless you don't know a specific characteristic, clinical and family characteristic of the patients. I don't know if I was able to answer completely.
If I can add something, Julia, I would also say that the other thing is about the length. So you talked about the number of genes on the panel, but it's also the length of the reads of the genes. And so the shorter the reads, then the more difficult it is to pick up large deletions. Now, in the time that I've been doing NGS, there's already been really big improvements in how we can try and pick up deletions, and that's to do with sort of bioinformatic ways of counting how many reads there are. And so if you see that half the number of reads that you expect, then that tells you that probably you've got a deletion there. But the problem with doing the targeted panels is that it relies on some amplification of the DNA, and because some regions amplify better than others, then it's a little bit artificial when we're comparing numbers of reads. So the longer the reads and the less amplification you need, the more accurate it is and the easier it is to gather copy number variants. And that's why whole genome sequencing is better than targeted panels. But also, if we're thinking about the future, because one of the questions, we've only got 4 minutes left, I thought one of the questions that might come up is people asking about whole genome sequencing and whether is everything going to go to whole genome sequencing, because that sounds so much better than a targeted panel. But although it is much better, it also brings in so many more complex questions around analysis of variants and storage of data. But there's also new technologies that use super long reads. So as far as I'm aware, they're not available yet. So things like Oxford Nanopore. But you can imagine that if you're reading, you don't need amplification. You just have a single strand of DNA that you can read and sequence, then it's going to be much more accurate to be looking at copy number variants.
Yeah, definitely. That's the point, yeah. And the reverse, is there any place for the Sanger technique? Again, or still?
Yes, for me, yes, Sanger sequencing is can be considered still. It is still a gold standard for diagnostic settings, at least in Italy. And
in which case do you use Sanger?
We use, for example, Sanger sequencing for G6PD deficiency, because we have two mutations that are highly common, that are the Mediterranean Seattle variants, and so we check directly for these two variants. But when we have to go ahead with the analysis of the entire gene, we directly moving on the NGS approach. We still use, for example, Sanger sequencing for erythrocytosis, Chuvash polycythemia, that is related to only one variant in von Hippel-Lindau gene, and so a few, and also to solve the problem of some high similarity regions, because we perform long PCR and then we sequence these regions by Sanger sequencing, but mostly to confirm the data obtained by NGS in this case.
You don't use a snapshot? Or the...
No.
And regarding the paper, do you plan to update what this huge piece of work each, I don't know, 3 or 5 years, or what would it take?
It's a good question, Lizzie. I think it only just got published. I think the thought of having to revise it is a little bit depressing at this stage. But maybe I should add also, one thing we haven't said is that we've put in a sort of list of suggested genes, and of course this list of suggested genes will change very frequently as more and more research gets done. But we would like to keep this up to date, of course, until the technology completely changes and we have to write completely new guidelines.
And I hope it will be the beginning of a work in Europe. We will discuss the variant, like you said in the
yes, absolutely.
I don't know how to do that, but definitely it would be a good idea to make a group of discussion.
And we have done a few years ago, 2017, I think it was already, we did a EQA, so external quality assessment. So we had a data interpretation test on a test patient, and we were able to compare how the different labs were reporting it. So I think it would be nice if we carry on with that.
Yes, if I make a comment, I need also to update not only the technology or panel or gene list, but we need also to update the variant analysis, not only focusing on, for example, nonsense, missense, but also, for example, looking at synonymous variant, because they often may provide alteration of splicing. They could be highly relevant.
That's true. But did you look at synonymous variant right now? Or?
Yes, we focus on that also.
Really? And you find some? Okay.
Yes, yes, yes.
In which gene?
It depends. Depends. Also in a lot of variants, of course, in PEZ1, but PEZ1 has a lot of variants in general. But we obtained also variants, observed also variants in, for example, SEC23B gene. It depends on the position of the mutation within the exon. For example, it is located in the last base of the exon.
I think we need to close the session because we finished. So thank you so much, Yuri, Roberta, and Naomi, and it was a pleasure to be with you this afternoon and all people everywhere that I don't see. Bye-bye.
Bye.
Bye.